jurors enter.
Welcome back, everyone. Thank you all so much. We're going to continue with direct examination.
Thank you, Your Honor.
All right, thank you.
May I please report?
Yes, thank you.
Jurors? Where we left off, Dr. Robb was talking about Dr. Shearer, who's the surgeon. Now, what's the most likely reason at this point in time, given your knowledge and experience of the diagnostic process, for Mrs. Adamson to go see a surgeon at this point?
That she's a possibility to have surgery to remove a tumor.
In your experience with Mrs. Adamson had been consulting a surgeon if they had found cancer on the brain or bone scan?
Still possibly could, but probably not for curative purposes.
Based on what we know from the depositions and the calendars, at this point in time, does it appear that Mrs. Adamson's doctors thought they could perform surgery to cure or remove the cancer?
Potentially not cure, but definitely that they could remove a cancer.
Based on your education, training, and experience, were Mrs. Adamson's doctors, based on the information they had at that time, likely treating her for what they believed to be primary lung cancer?
I think so.
Do we have information from the calendar about Mrs. Adamson undergoing radiation therapy in the last few weeks in June, or middle of June into the last few weeks?
Yes.
From the testimony in the Rhode Island records, do we have information that Mrs. Adamson was receiving radiation at this time to shrink the tumor before surgery?
Yes.
And is that consistent with your understanding of typical procedure before surgery on a lung mass?
For a primary tumor, yes.
Now, up to this point in time, do we have any clear picture of what doctor or doctors are directing Mrs. Adamson's care?
Not specifically, no.
So then let's go to August 3rd. What does this entry say?
It says biopsy on leg, surgery postponed.
Is this consistent with Ms. Coughlin's testimony in her deposition that her sister found a lump on her groin, it was biopsied, and as a result, surgery was postponed?
It's consistent, although the leg is different than the groin.
Do we have any record of who the pathologist was who would have interpreted this biopsy?
No, we don't.
Do we know what pathologist or radiologist or surgeon took the biopsy?
We don't.
Do we know whether it was the same pathologist who interpreted this biopsy as her prior biopsy from her lung?
No, we don't.
Do we know what, if anything, the pathologist had who was interpreting this biopsy as far as a history?
We don't know.
Do we know what the results of this biopsy were?
Not based on the calendar right here.
Do we have other information in the records that we know what the results potentially were?
Well, it looks like from the Rhode Island records that she was reported to have a perineal cancer, or CA, which would mean cancer.
And so does that match up with this notation from August 3rd and the deposition testimony from Christine Coughlin about a second cancer being found?
Yes.
Why would you postpone surgery after cancer is found in a new location?
Well, it could reflect widely metastatic cancer from either the lung or possibly from another site.
Do we have some notations in the Rhode Island records that talk about where the biopsy was taken and what it showed?
Well, the biopsy of this area, it showed what they just wrote as CA or showed as cancer.
And so you said the perineal area.
Yes.
Did we bring a body diagram for you to use to help explain to the jury where cancer was found in Mrs. Adamson's body?
Yes.
Would you like to, may I approach you, Honor?
Sure, of course.
Would be helpful for you.
Sure, that's fine.
would it be helpful for you in explaining to the jury where cancer was found in Mrs. Adamson's body for you to come down off the stand and use this chart or the diagram?
Sure. May I?
Yes, of course.
And I'll hand you these markers.
Okay.
First, Dr. Robb, before we get into the second cancer that was found, could you please demonstrate for the jury or mark for the jury where the cancer, at least from what the information we know, was found in Mrs. Adamson's lungs back in May?
Well, these are the right and left lungs right here, these little pink things here. And so the information from the Rhode Island records would indicate she had at least had a right upper lobe mass, which would be, that's the upper lobe of the right lung.
Could you please, Dr. Robb, mark for the jury and explain what the perineal area is that was referenced in Mrs. Adamson's medical records?
The perineum is the area that's located down here between the legs, and it encompasses the area around the rectum as well as the area around the vagina. So it would be in this area right here. You would be looking up, it would be all the way back to the rectum and front towards the vagina.
Based on the fact that Mrs. Adamson felt the lump herself that was ultimately biopsied, where specifically do you think the cancer was in the perineal area?
We just know that it would be probably here or deeper into the tissue as well, but we don't know the full extent of where the tumor may have been.
From your experience and from what you know from the records and the depositions, are you thinking that this is a skin cancer in the perineal area?
Well, it either could be a skin cancer or it could be a metastasis to the skin region. And perineal cancers are actually not that common primary, but tumors can metastasize there, and this could be tumors that are in the local area here, or it could be from distant sites.
And you know what, you actually pointed out that I asked a bad question. I guess more of my question was, is your belief based on the information we have about her actually feeling the lump, that the cancer was on the skin in the perineal area?
Well, we don't know, because usually lumps are deeper into the body than the skin. Then it would be like a little nodule on the skin, but a lump usually refers to soft tissue swelling.
Okay. Now, did you see any later materials noting a concern about, by the doctors about a concern of a mass on her forearms?
Yes. I think it was right. I forgot specifically which side.
Well, you don't have to mark it right now, but
I think she also had a soft tissue, if I could look at it, where it sounded like a mass on, I think, one of the forearms, and I think it was right.
I think you're right. Well, can adenocarcinomas metastasize to the skin?
Yes.
Which ones?
Well, all adenocarcinomas can metastasize to the skin, from lungs to adenocarcinomas that arise in the colon or the higher up in the GI tract or from the gynecologic tract. All those could metastasize there.
Do gynecologic and breast cancers more often metastasize to the skin than other adenocarcinomas?
The more common sites would be, yes, breast, gynecologic tract, and melanoma.
Now, I want you to assume that Ms. Coughlin testified that it was her understanding that the cancer metastasized to the lymph nodes in the groin area. Where would that be located? Is that different from the perineal area?
Well, some people confuse them, so it's difficult to say specifically. But the lymph nodes in the groin run kind of right along this chain here, and they're adjacent deeper to these vessels that are present here, so that the red is an artery, the blue is a vein. So they tend to lie along this area here, and the extent may be down to the perineum, but we don't know if they meant that area or higher up in a lymph node.
So based on the information that we have, could Mrs. Adamson have had cancer in the perineal area, those lymph nodes in the groin area, or both?
That's true, she could.
Had Mrs. Adamson's doctors done any type of workup prior to this date to identify a cancer in this area?
Not that I know.
Does primary lung cancer typically go to the perineal area?
It's unusual.
In all of your years of practice, your thousands of cases you've seen, have you ever seen the perineal area as the first site of metastasis for a primary lung cancer?
I have not.
Where does cancer go first if it spreads from a lung primary?
Well, it can go to different areas, but it often goes centrally to the hilum here, or it can, if it's a peripheral tumor, it can go outwards into the pleura, and then it can move through the lymph chain, up and down, and also up here, and then down this way.
So are the mediastinal and hilar lymph nodes in the middle of the chest typically the first site of metastases for a primary lung cancer?
Yeah.
Would Mrs. Adamson's doctors have been able to identify cancer in that area based on the chest X-ray and chest CT scan that she had gotten done previously?
They may have, yes.
I mean, chest CT scans will typically identify mediastinal and hilar lymphadenopathy, right?
Yes.
Cystine.
Sure. Is it true that typically CT scans will identify cancer in this area?
Yes. They show masses, and there'd be masses in the hilum or around the lymph nodes here.
Do we have any evidence here that Mrs. Adamson's doctors ever found cancer in her mediastinal or hilar lymph nodes?
We don't know.
I want you to assume the jury has heard that Mrs. Adamson likely had cancer here. Is there any evidence of that?
We don't. I didn't see any evidence showing that.
How common is it for primary lung cancer to spread to the lymph nodes or the perineal area without first going through the mediastinal or hilar nodes?
It'd be unusual.
Would you say very rare?
Yes.
How often do gynecological cancers go to the perineal area?
Well, the gynecologic tract is right here, right adjacent to it. These are the ovaries, and this is the uterus, and this is the cervix. And so they're adjacent to it, and they would drain into those lymph nodes.
How often do breast cancers go to the perineal area?
Less frequently, but they can, because breast cancers can move along the lymphoid chain. These little green things here are lymph nodes all the way down here, but they would also be here as well in the mediastinum.
Do gynecologic cancers and breast cancers go to the perineal area much more commonly than lung cancers, primary lung cancers?
It's more common.
Did the doctors also find cancer in Mrs. Adamson's brain at some point?
Yes, and that's what they were treating in March.
Is the brain a place of metastases for a lot of different types of cancer when there's widespread metastases?
Well, if there's widespread metastases, tumors can go anywhere, yes.
Based on this metastatic pattern, is it a possibility that Mrs. Adamson had breast cancer?
It's possible.
And based on this metastatic pattern, is it a possibility that Mrs. Adamson had gynecologic cancer?
Yes, it is.
Can you have a large gynecological tumor that goes undetected?
You can have tumors within the pelvis and in the abdomen get large because you can grow larger tumors there that wouldn't have any signs and symptoms, because in other areas there's often compression so that the tumor cannot grow that large without causing signs or symptoms. But in the abdomen and pelvis, there's more room to grow, so you can get very large tumors. And some women with ovarian tumors can have tumors that are 100 pounds and weigh, be 20 to 30 centimeters in large, like this large.
Can large breast tumors go undetected?
Yes, depending on the size of the breast.
How often have you seen a breast cancer first diagnosed by metastasis to the lung?
I've seen it occasionally, so I have seen
it. Is lung a possibility for the primary site here as well?
It's possible.
Can you say Mrs. Adamson's cancer started in any one of these sites to a reasonable degree of medical certainty?
Right. think there's a lack of evidence to be able to actually ascertain that, so no.
And you said earlier that your opinion in this case is that the diagnosis would be a cancer of unknown primary. Is that a real medical diagnosis?
Yes, it is.
Were thousands of people diagnosed with cancer of unknown primary in the 1990s?
Yes.
All right, Dr. Robb, thank you. You can return to the stand. So let's continue then going through the calendars and Mrs. Adamson's cancer course. If we look at August 7th, it says 2 o'clock, Dr. Furtman. Is Dr. Furtman a radiation oncologist?
Yes, Dr. Furtman is.
Do we have any records from Dr. Furtman?
We do not.
Do we know if Dr. Furtman was the one that was performing the radiation prior to this date?
We don't know.
What does August 10th say?
It says Dr. Patton, Good Samaritan, and it looks like it's crossed out.
Is Dr. Patton a surgeon at Good Samaritan?
Yes, Dr. Patton is.
Do we have any records from Dr. Patton or Good Samaritan?
No.
Does it look like it's crossed out, I think you said?
Yes, I did.
Is that consistent with her earlier record of a notation of surgery being canceled?
It could be. I don't know.
Now, at this point in time, in early August, do we have any evidence that Mrs. Adamson had seen a medical oncologist?
No, not now.
So what's the first time we have evidence that she saw one?
It looks on the 18th or 19th in that area.
How long was this after the cancer was first discovered in Mrs. Adamson's lung?
6 weeks, 7 weeks.
When Mrs. Adamson saw her oncologist for the first, Dr. Spitz, for the first time in August, what stage would she have been?
Well, it depends. It sounds like if the tumor from the peritoneum, or excuse me, the tumor in the perineum is a metastasis, or the lungs a metastasis or something, one of those things, then she would be at end stage of whatever cancer it was, having wide metastatic disease.
And so what do you believe, based on the information you've seen, as far as whether the lung and the perineal area cancers are related?
Well, I think they probably are, as it's being treated as canceling surgery would indicate that they think something is metastasis, and that therefore she would probably no longer be a candidate for surgery, but could be a candidate for both radiation therapy and chemotherapy.
And so given your belief that you think those two cancers are related, what stage would Mrs. Adamson have been at this time?
High grade, stage 4.
Stage 4. Do we have any records from Dr. Spitz?
We don't.
Do we know what diagnosis Mrs. Adamson went to Dr. Spitz with?
We don't.
Do we know what, if any, workup Dr. Spitz did to either confirm the diagnosis, whatever it was, or investigate other possible primary sources?
We don't.
Now, with the being stage 4, with the discovery of the perineal area cancer, was Mrs. Adamson curable at this point?
Most likely not.
So what would Dr. Spitz's role have been at this point in her course?
To probably coordinate chemotherapy.
And would that most likely have been designed as palliative care to prolong her life as much as possible?
I think so. I mean, there always is the hope that you could cure, and rare patients may be cured at that high stage, but probably for palliative care.
Given Mrs. Adamson's stage at this point, when Dr. Spitz became involved in her care, in your experience, would her doctors have been concerned with confirming a primary?
If they're going to be treating them the same way, probably less likely would it matter to them.
Would their main concern at this point have just been to decrease the tumor burden in her body?
Yes.
What's tumor burden?
Tumor burden is the amount of tumor that is present. And if it's a local tumor, then the size of the mass is the tumor burden. But if it's metastatic, it's everywhere in the body. So the burden could be wherever the sites it has metastasized to.
Let's pull up the entries for August 21st and 25th. Do those reflect picking up, prep from X-ray for CT scan and CAT scan of abdomen and pelvic forearms? Do you see that?
Yes.
Would CT scan of the abdomen and pelvis be part of the standard workup at this point in time, based on what we know about Mrs. Adamson's cancer?
Well, it could be looking for source of tumor arising from there, or burden of tumor if they believe there's a large burden of tumor that is present there.
Do we know what the CT scan of the abdomen or pelvis showed?
No, we don't.
Is a CT scan of the forearms part of the standard workup for a widespread metastatic cancer?
Well, if there's a mass there, then they might want to CT that to see the size.
But as far as the typical standard workup, if somebody's thinking that this is a primary lung cancer, would you see, in your experience, a CT scan of the forearms?
Rarely.
And I think you mentioned this, but do the Rhode Island records reflect a semi-firm mass on her forearm?
Yes, they do.
Do we know if the mass on her forearms was ever biopsied or whether it was cancer?
We don't know.
Does the fact that they appear to be doing a CT scan of that area on August 25th mean that her doctors were at least concerned about the possibility that this was cancer?
Yes.
Let's go to the calendar entries for 8/31/91/92. Do they reflect that Mrs. Adamson is undergoing chemotherapy at this point?
Yes, she is.
Are you a medical oncologist?
I am not.
Do you prescribe chemotherapy?
I don't.
Throughout the course of your career, are you familiar with the different types of chemotherapy given for different types of cancer?
Sometimes in some cancers, yes.
As far as you know, is this chemotherapy agent given specifically for primary lung cancer?
They could be given for different cancers.
It appears that she had a bone scan on September 2nd. Do we have any information about why that was done or what it showed?
We do not.
Now, do the calendar entries from early September reflect that Mrs. Adamson was still getting radiation and had gone to a follow-up visit with Dr. Spitz?
Yes.
So let's go to the last 2 days of September and the first day of October. This notes simulation with Dr. Furtman. Please explain to the jury, what is a simulation?
For radiotherapy, simulation is performed where they simulate giving doses of radiation, where they don't actually do it as sort of a pre-workup. And what they're trying to do is exclude organs that may be heavily damaged when you radiate them, as well as radiating the tumor by beams of radiation coming in at different angles. So it's a planning process that radiotherapy does to both target tumor and protect organs that we don't want to have radiation beam at.
Based on your experience, do you know why a simulation would be needed at this point after she'd already been getting radiation, presumably to her chest?
Well, it looks like they're planning more radiation treatment, but I don't know where.
Given that we know she was going through a simulation, based on your experience, does it appear that they're changing the radiation field?
It's possible.
Do we know where the radiation was directed after the simulation?
No, we don't.
And at this point, as far as we know, had the brain metastases clinically presented themselves yet?
Not that we know.
When do the records say that Mrs. Adamson first received radiation to her brain?
It was in December.
So based on that information, is it likely that the radiation after the simulation was directed at the brain?
Could you repeat that?
Sure. After the simulation, where they're presumably changing the radiation fields, is it likely that it was directed at the brain?
Not at this time unless there were symptoms, but I don't know.
Could the radiation have been directed to the perineal area where they had found cancer?
It's possible.
Could the radiation have been directed somewhere else that we don't know about?
Yes.
So let's look at the entry for October 9th. And I think I might have missed it along the way, but do we have some information about Mrs. Adamson being seen by St. Mary's Medical Center in the calendars?
I think it's written, but I don't remember specifically where.
Okay. Well, do we have any records here from St. Mary's Medical Center?
We do not.
Now, is Dr. Heimbeck an OBGYN?
Yes.
Do we know why Mrs. Adamson would have an appointment with an OBGYN at this point in her course?
We don't know.
And do we have any records from Dr. Heimbeck?
We don't.
Let's look at the entries for October 21st and October 22nd. Do we have any information about this CAT scan that's reflected for October 21st?
No, we don't.
Do we have any information about where that CAT scan, what organ it was of?
No, we don't.
She also has good news written here. Looks like an arrow pointing from the CAT scan to the good news. Do we have any information about what that good news was? So if we skip ahead to December and look at December 12th, 14th, and 18th, do we have evidence that Mrs. Adamson traveled to Houston, Texas to go to MD Anderson?
Yes, it looks like that's what you did.
Do we have any records from Mrs. Adamson's visit to MD Anderson?
No, we don't.
Do we have any information about why Mrs. Adamson went to MD Anderson at this time?
We don't.
Do we have any information about any workup done at MD Anderson?
No.
Do we have any information about what the doctors at MD Anderson concluded, if anything?
We don't.
So let's go to January of 1993. Does Mrs. Adamson still continue seeing her medical oncologist, Dr. Spitz, at this point?
Yes.
If we go to January 19th, we have appointments with Dr. Spitz and Dr. Wimbush. Is Dr. Wimbush a radiation oncologist?
Yes.
Do we have any records from Dr. Wimbush?
We do not.
Do we know why Mrs. Adamson would have switched to Dr. Wimbush from Dr. Furtman for radiation in January?
We don't know what happened, so we don't know.
And do the Rhode Island medical records reference any radiation being done in January?
No.
Do we have any other notations in the calendar pages after January of 1993?
We don't.
You talked earlier, Dr. Robb, about that circle of the patient care. And you also talked about the transfer of medical information between providers and how communication failures can lead to medical errors. Specifically, as to Mrs. Adamson's case, what we just looked at, did she see a good number of different doctors that were practicing in different facilities?
Yes, she did.
In your experience, how would Mrs. Adamson's medical information have had to be transferred between providers at this time?
How, you asked?
Right. How would they have transferred the medical information from one provider to another at this time?
They would either have had to share their large number of medical records or communicate with them in other forms, such as speaking with all the different providers.
Did you bring a demonstrative slide to illustrate your point about the transfer of information between medical providers and how communication failures can occur?
Yes.
So let's bring up the first slide. So, for instance, if we take Dr. Steinberg, the internist that Mrs. Adamson first saw, and Dr. Spitz, her medical oncologist, Could you please explain this demonstrative and the type of transfer of information that would have had to occur between them and the patient for both of them to have all the information that the other one had?
Well, the patient is in red, and the red lines are related to information that is flowing back and forth between Dr. Spitz and the patient and Dr. Steinberg and the patient. Now, in order to coordinate this care, Dr. Spitz also would need to communicate with Dr. Steinberg about various aspects of what's going on and various tests that one may order and the other one may not be receiving to be able to provide that information to them. So even with a couple people that are working in silos that are separate from each other, there may be loss of information, because one of the challenges is the more that you have to communicate, the more opportunities that you have to lose information or information is lost or garbled. And this also includes to what the patient may know that either of these two physicians know that she may not know, depending upon tests that are done. So it just represents the fact that all information needs to flow to everybody with the patient in the center for there to be safe care. And the more people that are involved in the process that are doing all different things, and the more times you may change a provider, such as having one radiation oncologist and then another, as well as going to other institutions, can potentially limit the accuracy of information or the information to anybody. And so what happens is that we know that care is delivered, but we don't know at what level and what the different people may know at the time, as time goes by, related to what a diagnosis is or how they're treating or how someone new maybe is coming in to do treatment.
I may approach just.
Sure, please.
Do we have any information about any of this transfer of information?
No, we don't.
Did you bring another demonstrative to demonstrate beyond just Dr. Steinberg and Dr. Spitz, all of the different doctors and facilities, and what would have had to happen as far as transfer of information between those?
Yes.
So if you look at that, the next one.
So when you have multiple institutions involved doing multiple things, with the patient still in the center, with multiple individuals from those institutions all having separate roles in their care, it becomes a very complex task of actually coordinating the care so that everybody knows everything that's going on. And so oftentimes people then switch to just what they may be doing, say palliative care. And it comes a course of everybody doesn't always know everything that really happened in the beginning of the care. If now we're treating someone for palliative care, which is a gap of information that'd be critical for knowing what may be the primary, but maybe not for doing terminal care therapy.
So is this realistic as far as the transfer of information between every single facility and provider to think that they all had the same access to all of the information about Mrs. Adamson?
They probably didn't.
And do we have anything in the records to demonstrate or fill in the gaps of any of these lines?
No, we don't.
Do we have any way to know what information each of her doctors would have had at the time they were seeing her?
We don't have any of the records, so we don't know.
And with your background and research in the misdiagnosis of cancer, what types of issues can arise when you have this kind of lack of transfer or questionable transfer of medical information?
Well, this is where medical errors arise, or where we have garbled information and don't quite understand everything that has happened at an earlier phase in the treating or diagnostic process.
And how does that opinion relate to your opinion here that there's insufficient information to say, more likely than not, that this was primary lung cancer?
Well, like I said, I think that there is complete lack of information that we know, let alone the complete information of how they were transferring it, with enough other evidence that there was a secondary tumor that we don't know what everybody was thinking at the time or the reasons behind of why they were thinking that she had a primary versus a potentially secondary tumor.
Before we get to Rhode Island Hospital and the records we have from there, let's go back to MD Anderson. What kind of facility is MD Anderson?
MD Anderson is a cancer center.
And is MD Anderson a place for specialized treatment of cancer?
General and specialized, yes.
And so what care do they typically provide?
They can either provide sort of esoteric type of treatments that may not be offered elsewhere, or they can be gone as a consultation service to see if they would recommend different types of treatment, or just do general treatment.
So based on your experience, what reasons could Mrs. Adamson have gone to MD Anderson for?
She could have gone for a second opinion of what either treatment or diagnosis was. She could have gone there for treatment or for treatment options, or she could have gone for, something that would be done differently there than at other institutions. But mainly it's for the second opinion and follow-up of that.
And so does this information about her going to MD Anderson Cancer Center add to the unusual nature of this case with the cancer that appeared in the perineal area?
Yeah, we don't know what actually happened there, so we don't know what they did, but we don't know what the target of what she's doing is either.
Does the fact that she went there at least suggest that there were questions about the type of cancer that she had?
Possibly, yes.
So, we mentioned earlier, we do have records from Rhode Island Hospital, right?
Yes, we do.
Why did Mrs. Adamson go to Rhode Island Hospital?
She went there to have gamma knife surgery of metastases to the brain.
Is that a type of radiation therapy?
Yes.
And are you familiar with the specific requirements for approval for this gamma knife treatment at Rhode Island Hospital?
Not the specific requirements, no.
Do you have general familiarity with this type of treatment and whether this type of treatment is specific or not for primary lung cancer?
It can be done mainly for metastases, and in this case to the brain, for primary, secondary, or from other sites.
So at least as far as what you know of this type of treatment, would it have been required for Mrs. Adamson to have had a primary lung cancer?
Sure, of course.